All right, today we are diving into two of the most powerful, high-stakes drug classes in all of medicine, antiplatelets and thrombolytics. Now, they both deal with blood clots, but they do it in completely different ways. You can think of one as a security guard, right? Just patrolling and keeping things in order. The other, that's the SWAT team, busting down the door. So how do you know when to call the guard and when you gotta send in the SWAT team? Let's break it all down.
So to really get a grip on these drugs, we first have to understand the two very different problems they're built to solve. It's really a tale of two clots. And this slide just lays out that difference perfectly. Over on the left, you've got the threat. This is where platelets, these tiny little cells in our blood, they start getting sticky. They're clumping together in an artery. You can see a problem is brewing. But then on the right, you have the emergency. That little clump has turned into a full-on thrombus. It's completely blocking blood flow. This isn't a threat anymore. This is a heart attack or stroke happening right now.
Okay, so to handle the threat, that brewing problem, we call in our first team, the prevention squad. Let's meet the antiplatelets.
The whole job of an antiplatelet drug is actually pretty simple, but it's elegant. They just make platelets less sticky. I mean, you can think of it like a nonstick coating for your blood vessels. By keeping those platelets from clumping up, or aggregating, as we call it, they can stop a dangerous clot before it even gets a chance to start.
Now, what's really cool is how the most famous antiplatelet, aspirin, actually works. This isn't just a temporary fix. When you take an aspirin, it gets in there and it permanently shuts down a key enzyme in the platelet. This enzyme is what creates the signal that tells all the other platelets, hey, let's clump together. So by blocking that signal, the platelet is basically silenced. And because it's irreversible, that one platelet is out of the game for its entire lifespan, which is about 7 to 10 days. And you can see here just how versatile these drugs are. On one hand, they are the absolute cornerstone of long-term prevention. I'm talking about that daily low-dose aspirin for someone who's at risk. But on the other hand, they have this critical role right in the middle of an emergency. If someone is having a heart attack, chewing a full-strength aspirin gets that antiplatelet action working super fast, right when it's needed the most.
Of course, any powerful tool is going to come with risks, and this table is great because it helps us separate the common annoyances, like an upset stomach, from the real dangers. A bleed in the GI tract, that's serious. And tinnitus, that ringing in your ears, that can actually be a sign of aspirin toxicity. It's a really important difference to understand. So, what happens when prevention isn't enough? What if we're already facing that full-blown emergency? Well, that's when you call in the heavy hitters, the emergency crew. Enter the thrombolytics. So right off the bat, the most important thing to get is that these are not for prevention. Thrombolytics, or as we call them, clot busters, they're the demolition crew. These are classic high-risk, high-reward drugs. You only use them in a life or death situation to completely dissolve a clot that's causing a stroke or a massive heart attack. And the way they work is, well, it's pretty incredible. A drug like Antiplatelets, or TPA, actually goes right to the clot and binds to the fibrin mesh that's holding the whole thing together. Then it activates a substance called plasminogen, turning it into something called plasmin. And plasmin is an enzyme that literally digests the clot from the inside out. It just eats away at it, dissolving it, and hopefully restoring blood flow to that starving tissue. Now, when we talk about thrombolytics, this number you see here is everything. For a stroke caused by a clot, an ischemic stroke, this drug absolutely must be given within 3 to 4.5 hours from when the symptoms started. Why? Because after that window closes, the risk of causing a massive, catastrophic brain bleed becomes higher than the potential benefit. The saying in the ER is time is tissue. Every second counts. And because these drugs are so incredibly powerful, the safety checklist is non-negotiable. I mean, this is not a list of suggestions. These are absolute deal breakers. If you give a clot buster to someone with active internal bleeding, it could be fatal. And that's why you must get a CT scan of the brain first to prove that the stroke is from a clot and not from a bleed. Okay, now for the main event. Let's put these two drug classes right next to each other, head to head, to really make sure these differences stick. And here it is. This is the single most important distinction. If you remember nothing else, remember this. Antiplatelets prevent. Thrombolytics dissolve. One stops the fire from ever starting, the other is the fire department putting out the inferno. So you can see how different their day-to-day use is. Antiplatelets are often part of a daily routine, right? A long-term prevention strategy. Thrombolytics? No way. That is a dramatic, maybe once-in-a-lifetime intervention for a sudden, life-threatening emergency. And their risks have totally different personalities. With antiplatelets, the big worry is often a chronic issue, like a slow bleed or stomach ulcers developing over a long time. With thrombolytics, the danger is sudden, immediate, and potentially catastrophic bleeding anywhere in the body. But the one that terrifies everyone is in the brain. So, with stakes this high, how do healthcare professionals actually manage to use these drugs safely? Well, it all comes down to following a really strict safety checklist. For antiplatelets, safety is all about diligence. Before you even give the drug, you're asking about things like a history of ulcers, and you're making sure it's stopped a good week before any surgery. And afterwards, you're trying to protect the stomach by giving it with food, and you're constantly monitoring for those subtle signs of bleeding or toxicity. Now, the thrombolytic checklist, that is a whole different level of intensity. It is all about minute-to-minute precision. Confirming exactly when the symptoms started is job one. Then you have to rule out every single contraindication. You even start multiple IV lines before you give the drug because you can't risk poking a vein after their blood can't clot. And then afterwards, it's just hypervigilance, constant neurologic checks, strict blood pressure control, the whole shebang. And hey, for anyone studying this stuff, a good mnemonic can be an absolute lifesaver. To remember some of the key antiplatelets, you can just think ACT for aspirin, clopidogrel, and clopidogrel. And for the thrombolytics, you could use something like S2A-TPA to help remember the major drugs in that category. But look, if you walk away with only one single thing from all of this, let it be this right here. Antiplatelets prevent the clot. Thrombolytics dissolve the clot. That is the core, fundamental principle that separates these two powerful and life-saving classes of drugs. And this kind of leaves us with a final, really interesting question to think about. As our technology gets better and better, and we get better at predicting who is most at risk for forming a dangerous clot in the first place, how is that going to shift our strategy? Will we see a future with more powerful, more aggressive prevention, maybe making that high-risk, last-ditch intervention of a clot buster a thing of the past? It's a fascinating thing to consider for the future of medicine. Thanks for joining.